Next, we'd like to have the second keynote address. And the title is Current Status and Challenges Facing Medical Care and Long-Term Nursing Care in Japan, a Super Aging Country. Dr. Isawa Endo, Director General of IPSS, will be the speaker. Dr. Endo, please. Thank you. My name is Endo from the National Institute of Population and Social Security Research. My expertise is in health economics. I'd like to talk about how longevity affects healthcare systems and long-term care systems in Japan. First, let me briefly talk about the characteristics of the future population in Japan. I think it's best to look at the charts. So please look at this graph. So the Japanese population structure and estimates for future population is shown here. The future population was estimated by IPSS, our institution. So we can read several facts out of this graph. First of all, the late-stage elderly people, in other words, those people over 75 years of age, will continue to increase and will peak around 2030. And from then on, it will slightly decrease, but will be basically constant. Secondly, the early-stage elderly, so the population from ages 65 to 74, has already peaked out in 2016 and has been gradually declining since then. And what can be said that in thinking about longevity, there will be an increase in the population of the late-stage elderly. And I will be discussing this later, but this will have a major impact on the sustainability of long-term care insurance system and countermeasures against dementia. The productive age population, on the other hand, has already decreased since 1995, and the young population under the age of 14 has decreased constantly. Thus, the ratio of the late-stage elderly to the total population will rise constantly, and in the future estimate, the value will reach 25% in 2065. In other words, 1 out of 4 people in Japan is predicted to be late-stage elderly. So this is a very serious problem considering the burden to the social security system. Another characteristic of Japanese longevity is the increase in elderly population does not occur uniformly throughout the country. The increase is mainly seen in the big metropolitan areas, the Tokyo area, the area around Nagoya, and the area around Osaka. The number of elderly people increasing in the remote rural areas is slow in comparison. Their big issue is the overall decline in the population. So this graph shows the future estimate of population over age 75 by region. And so based on the population of 2015, so if this is set at 100, Saitama Prefecture and also Tokyo will be quite high. Or on the other hand, Yamagata and Shimane, which are remote rural areas, will be nearly unchanged in 2040. And from a different perspective, as you can see in this graph, this is an estimate of how much the population age 65 and older will increase from 2005 to 2025. It shows that Tokyo, Kanagawa, Osaka, Saitama, Aichi, and Chiba Prefecture, the whole 60% of the whole increase will occur in these areas, and the rapid aging of the population will thus take place in the big cities. And this is because the baby boomer generation moved to the vicinity of big cities in the area in the period of high economic growth and have lived there and aged there since then. Thus, longevity has an impact, obviously, on the social security system and expenditure. First, the impact on the expenditures themselves. Since many social security systems in Japan, compared to European countries, are targeted at elderly people, progress in longevity becomes a major factor that increases social security expenses. And on the other hand, the financial burden of social insurance premium will be borne by the people of productive age, and their share of the population will decline, so their burden will increase. So how are we going to deal with the cost burden of the younger generation, the people in their productive ages, and maintaining social security system? Another effect of longevity on social security is the medical care and long-term care that provide social security benefits by providing in-kind services. So we must change the quality and quantity of medical care system and long-term care system so that we can cope and deal with super-aging society. And as I mentioned before, since the speed and degree of longevity varies from region to region, such reform cannot be carried out uniformly nationwide. We have to reflect the individual characteristics of that particular region. Now, how does longevity impact social security expenditure? This graph, I think it would be best to look at the graph. And this is from 2001 to 2015. It looks at medical pension and long-term care, and this looks at the year-on-year growth rate of social security expenditures. The average growth rate of the GDP during this period is almost zero, and especially in 2009, it was a negative 4.1% due to the Lehman crisis, and thus the growth of GDP was almost zero. And compared to that, the growth of social security expenses, the benefits included, is much higher than the growth of GDP, and the biggest growth is seen in long-term care benefits and expenses, especially before 2004. It is big because the introduction of long-term care insurance system was seen in 2000, but even then, the rate of long-term care expenditure consistently exceeds that of other social security expenses. Now, looking at the same trend from a different perspective using this graph, so this diagram was published by IPSS from the Financial Statistics on Social Security in Japan. So if you look at the table here, from 2001 to 2015, medical care increased by 1.4 times, but long-term care increased by 2.3 times looking at the same period of time, and therefore the percentage of long-term care expenditure to medical care expenditure in 2001 was 15.5, but has risen to 24.9% in 2050, and therefore the increase in long-term care increases much faster than medical care expenditure. So this basically shows the same trend as the previous graph. So this graph shows the ratio of social security expenditure, of medical care and long-term care, and the aging ratio versus the GDP. Now, the expenditure to totally medical care and long-term care increased much higher than the growth of the GDP. Furthermore, among social security system, the longevity increases expenditure, and it is seen in medical care, pension, and long-term care. But with regard to the pension scheme, a mechanism called the macroeconomic slide, which adjusts the amount of benefits reflecting the trend of longevity and declining birth rate, has been introduced, and thereby we are trying to maintain the sustainability of the pension system. But we do not have a similar system for long-term care. So with longevity, long-term care and the related expenditure is going to become an even bigger challenge. So we'd like to take one step further in looking at medical and long-term care. So I mentioned that long-term care increase in expenses exceeded that of the expenses for medical care. Now, if we take a closer look, this table on the left-hand side is the growth of medical care decomposed into various factors. On the right-hand side, you see the factorial decomposition of the growth rate of long-term care expenditures. Now, there are some distinctive facts. First, as I have mentioned, compared to the growth of medical care expenditures, so the growth of long-term care expenditure is higher, unless there are revisions in medical fee schedule or increase in self-payment, since 2000, the rate of increase in the previous year was about 3%. But since 2012 and onwards, natural increase rate has declined to about 2%. And so the growth in medical care expenditure has come down, although it rose by 3.8% in fiscal 2015. But the reason here is very clear. A very expensive drug, a medicine, appeared, and since then, the government has taken countermeasures against high-price pharmaceuticals. So the increase rate of medical care expenditure for 2016 fell to a negative 0.4. And therefore, the average increase rate for 2007 and 2008 is below 2%. And on the other hand, the rate of increase in long-term care expenses over the previous year, unless the long-term care fee schedule is revised, is basically 4 to 5% year on year. And up this far, we have seen similar trends in past graph, but we are doing a factor analysis here. The green shows the demographic trends. So medical care and long-term care increase factors, and there are other factors. And so this is due to technological progress in medicine and drug, and long-term care. Other factors are not that big. In other words, it's just population and change and the aging factors that are the big factors that impact long-term care. And so the effect of longevity will be greater for long-term care insurance than for medical care insurance. So especially since from now on the late-stage elderly will increase in the future, it can be said that how to reform long-term care insurance system will become very, very important if we think about its sustainability. Now, next, please look at this graph. Basically, the message here is the same, but this graph compares the medical care expenses and long-term care expenses for the early elderly, 65 to 74 years of age, and the late elderly, those over 75. The average medical care expenditure per capita of the earlier elderly in 1 year is 554,000 yen. The average medical care expenditure per capita of the late elderly is 970,000 yen. In other words, the difference is about 1.6 times. On the other hand, in case of long-term care expenditure, the average expenditure per capita of the early elderly is 55,000 yen, and the average expenditure per capita in the late elderly is 532,000 yen. The difference is about 10 times. So from this, we can see that long-term care expenditure per capita increases very, very rapidly when becoming late-stage elderly. And the following stage, I'm sorry, I'm repeating the same message, but this is per capita, the medical care expenditure and long care expenditure to the right, the per capita medical care and long-term care, how this differs depending on the age. From 65 to 69, if medical care is set at 100, long-term care is 7.7. But if you take the age bracket, 85 to 89, long-term care is 78% to medical care expenditure. So this graph is a prediction of the number of persons requiring care estimated by the Ministry of Health, Labor, and Welfare. So this graph is the number of qualified persons who need care levels. So we look at the certification of the qualified people of the different care levels depending on the age, and so it's linked with the change in the structure of age in the population. So the upper graph is the more serious need care, so care levels 3, 4, 5. It's different from France in that Japan's level 5 is the more serious. The lighter cases are lighter care levels, so 1 and 2 are light care. 3, 4, and 5 levels are more serious, requiring higher levels of care. So care level 3, 4, and 5, and the light level 1 and 2, and the heavier need care level is 3, 4, and 5. So if you look at their shares and what can be said, so the more serious need care level 3, 4, and 5. So with longevity, they are more people in need of greater care, and they will need more expenditures, and that after 2025, there will be a rapid increase in the late elderly. The rapid increase in late elderly becoming not that significant. The growth rate will be a little sluggish. The growth rate of people with both severe care needs and light care needs will decline. Now, next, looking at medical expenses. So there is no age limit for medical expenses, but we have to look at medical expenses, especially for the elderly. If we look at the growth, what is the difference here? We are looking at elderly and non-elderly, and how the growth rates differ on an year-on-year basis. These two graphs show year-on-year growth rate of medical expenses by age group. The blue line is for the elderly. The red line is the non-elderly. So the definition of elderly versus non-elderly is written at the bottom. And so depending on the timing, the definitions may change. But if you look at the left graph, what this shows is that the growth of overall medical expenditure, the per capita is greater. And on the right, you see the medical expenses per capita comparing elderly versus non-elderly. And on the right-hand side, it's opposite in that the growth rate to the left the elderly people exceed that of the non-elderly. However, the graph on the right shows the growth rate of the medical expenses of the elderly people per capita is lower than the non-elderly people. So we have succeeded to some extent in cost containment of medical expenditure for elderly people. Although if you look at a graph on the left, the overall medical expenditure in terms of absolute value, the growth is higher for medical care of the elderly because we are seeing more elderly people. And so the growth rate for medical expenses for the elderly is about 3% or so, and on a per capita basis, the elderly expenditure growth rate is becoming a little lower. So we have to look at the difference, and maybe there is a shift to longer-term care. But those are the basic trends for medical care expenditures. So there have been changes. See, now looking at this from the different perspective, looking at gender differences, elderly men and women, and looking at the average life expectancy and the healthy life expectancy, and you can see that there are particular issues relating to elderly women. You can see that in 2013, women have a longer life expectancy and longer healthy life expectancy compared to men. Healthy life expectancy is you are still old, but you can lead a normal daily life without health problems. It is calculated based on the answer resulting from the comprehensive survey on living conditions. The problem is the difference between average life expectancy and average healthy life expectancy. In other words, the difference represents the period of time that you are still alive, but you have clear health problems. In male, this period is 9.02 years. In female, it's 12.40 years. So women live longer, but are not necessarily healthy in the longer period of time that they live onwards. And if you are under 74 years of age, there is no big difference between men and women, but above the age of 75, the proportion of women gradually exceed men with regard to having problems at a higher age. And over 85 years of age, the male it's 46.7% and females 54.4%. But of course, it is also due to the fact that basically women live longer. So in this way, if this tendency is correct, it seems that women need higher care levels than men, and this table shows that point. So this shows the certification rate of each care level required by the age categories for males and females. And looking at the yellow portion, compared to men, women show higher rates of certification for more severe care levels. From 74 to 85 and over 90. So if you look at the different age brackets, compared to men, women need higher levels of care and have been qualified to receive that. So the care level of elderly women is higher than that of men. So from a variety of perspectives, especially for the very late elderly, women have more serious health-related problems, which may have important ramifications.
Next, this looks at the gender difference by disease. The proportion of medical cost is compared by gender for those who are 70 years and above by disease. For example, in the case of neoplasm, males 70 years and above account for 17.2% of the total medical cost, whilst the female patients' cost for neoplasm accounts for 9.4%. So this is all 70 years old or above. And if we look at each disease, the diseases with more than 50% difference between the genders are marked. And the diseases marked in green are those where there are more male patients, and yellow are diseases where there are more female patients. Male patients account for the majority of neoplasm, cardiac diseases, obstructive pulmonal diseases, and the like. And women occupy the majority of Alzheimer, arthritis, bone density, and behavioral disorders. And the key is bone-related diseases in the case of women, because that leads to bedridden risk, and it becomes one risk to increase the degree of care necessary. And concluding from what we've seen so far, longevity will lead to higher level of care required for female than male. And therefore, although this applies to male as well, it indicates the fact that we need to take more measures to prolong the healthy life expectancy of female and prevention measures. Next, impact to insurance finance. With longevity, medical cost and long-term care cost has been increasing, but let's focus on healthcare medical cost. What kind of responses have been implemented so far? If we look at the structure of financing of medical costs, as of 2015, Social Security premium accounted for 48.8%, slightly less than 50%. Public money, 38.9%, about 40%. Out of the pocket, 11.6%. Both medical insurance and long-term care insurance are run by Social Security premium. So the gap between the cost and premium income is filled by public money. And in medical cost, late elderly's insurance system for 75 and above, and national insurance system, which is with low fiscal basis, are the systems where much public money is injected, and therefore high percentage of medical cost is run through public money. And in 2015, as I said, public funds accounted for 39% in 2015. And the percentage in 2000 was 33%. In other words, that means that during those 15 years, the proportion of public money has increased by 6 points, from 33 to 39%. There are several reasons to this, but the late elderly's medical insurance system for 75 and above have very weak fiscal basis, and that is why the higher proportion of public money, and that's how the regime has been designed. So when the number of late elderlies increase with longer life expectancy, the proportion of public money in the total medical cost increases. In other words, we've been injecting more public money in order to respond to the increase in late elderly's medical cost. As you well know, public debt of Japan is already more than double of the GDP. We're the most indebted nation in the world, and fiscal consolidation is an urgent agenda, and there are limits to this kind of system. From a different perspective, let us look at the premium income and how premiums have been borne. This plots the trend in the premium rate for office workers. We've covered the health insurance societies for large companies and Japan Health Insurance Association for SME companies. And whichever system you look at, there has been more than 20% increase of the premium rate between 2009 to 2016. So the premium rate, the proportion of premium income against the total medical expense is going down, but the premium rate borne by each subscriber is increasing. By the way, in 2003, there's a dip in the premium rate for both systems. That is because from this year and beyond, the government began to include bonus in the calculation. And that is why they were able to reduce the premium rate. But this is just a one-off event. So we've been trying to respond to the increase in medical expense by increasing the premium rate. But can we go on with this avenue? That could be one option of strategy, but there are mixed views. To begin with, the Social Security premium rate in Japan is lower than the European countries, so some say that there's still room for further increase in the premium rate. On the other hand, with lower fertility, working population will decline, and there are those who are very hesitant in increasing the burden on the working population. So that's another view. Premium is linked to income level, and therefore the burden of premium per capita of the working population will increase significantly, and there are concerns about taking such measures. And if we are to talk about the burden on the working population, let us review the facts. Is aging truly increasing the burden on the working population in terms of insurance premium? And let me try to show you another diagram. On the left, by age bracket, we've plotted the per capita medical cost by age bracket. And on the right, out-of-the-pocket payment per patient and insurance premium paid per capita by age bracket. Of course, public money is also accounted for as part of the financing, and the percentage of public money is not included here or is not shown. And therefore, first of all, on the left, if you can take a look at the diagram on the left, per capita medical cost is high for neonatals, and then it goes down, and it bottoms out at 18 years of age, and then thereafter it begins to increase once again. On the other hand, the premium paid per capita is highest for the working age population around these age brackets. So through the health insurance system, there is a transfer of income from the working age population to the elderly generation. However, can we continue on with this pathway of working age population bearing the medical cost of the elderlies, and when you get old, that your medical cost will be paid by the working population? If that kind of cycle is sustainable, no problem. However, the demographics will change. It's no longer sustainable, which is shown in the next diagram. I showed you the 2014 per capita medical cost and out-of-the-pocket as well as insurance premium, and the same graph was made for 2000. So subtracting the value of 2000 from the values of 2014 is indicated on this page. During the past 14 years, healthcare cost has increased. So healthcare expenses, out-of-the-pocket, and insurance premium all have increased. But what is worthy of attention is the fact that the increase of premium paid by the working age population right here is increasing at a much faster pace than the increase of insurance premiums paid by the elderlies. But medical cost is increasing at a higher pace in the elderly households. So the biggest increase in the burden is experienced by the working age population. So these are the facts. To what extent are we requiring the burden to be borne by the working age population, and what kind of social system do we design? That's a big challenge. I've been trying to focus on the sustainability of the healthcare system and the long-term care system with this trend of lower birth rate and aging. However, as I have been saying, in order to respond to longer life expectancy, we have to change the medical or long-term nursing care system. There's inertia in any society, and people don't want to change the status quo. However, unless we are able to migrate to a system that responds to the increase in the number of late elderlies, we will be running a system where the benefit against cost is low. So there is no sustainability. Here, let us take a look at the difference in the characteristics of diseases between young and old. Young people become chronic patients of specific organs. So in many cases, they will recuperate if certain treatment is offered. On the other hand, many of the elderlies are suffering from chronic diseases. So rather than being sick in one organ, they feel pain all over their bodies. So this is due to aging, and therefore even with treatment, complete recuperation is difficult. In the future, we will see more elderlies, and therefore we have to change the healthcare system in order to accommodate to such demographic change. The treatment that is required by young people is hospitalization and intense care and recuperate at the earliest possible date so that they can go back to their ordinary lives. So diagnosis and treatment by organ and hospitalization to offer such treatment until complete recuperation. So hospitalization, hospital-based medical service is what the young people need. Of course, many elderlies sometimes suffer from acute diseases like young people, but they more or less suffer from chronic diseases. And the objective is, unlike acute diseases, not complete recuperation of certain diseases, but prevention so that the situation doesn't exacerbate. So from a different perspective, that means that the healthcare of elderlies has to be offered in a way where there is no clear demarcation between treatment and ordinary life. In the case of acute disease, for young people, they can be hospitalized, and then in an intense manner, resources can be input for treatment, and then they can be released after recuperation. However, the kind of medical service required for elderlies is not possible just by offering services by hospitals. In addition to medical treatment, there has to be long care service. So that would require diverse resources of local communities. So sometimes this is referred to as migration from hospital-based medical service to community-based healthcare service. And a more popular concept is the comprehensive community-based healthcare system. So medical service and long-term care service or lifestyle all have to be embedded in a comprehensive network. That is what is being sought at the moment. And there are several challenges in designing an effective system as such, so there are many difficulties. However, the requirement of such networks is broadly understood, and many localities are trying out several options. So, if we are to implement a reform in the medical and long-term care system, there's one thing we have to keep in mind. That is the different pace of longevity by region. In the case of large cities, the pace of aging is more rapid. So the establishment of a comprehensive community-based care system or the reallocation of beds that would be more accommodating to long-term care is necessary. But on the other hand, there will be decline of population in rural cities, so the number of beds will have to be reduced. This kind of reform in medical and long-term care system cannot be done uniformly on nationwide basis. That is why the involvement of prefecture or municipality is necessary. So the national government has come up with an estimate of the number of beds, hospital beds necessary, and home-based medical service necessary in 2025, and the statistics and estimates have been offered to each prefecture. And based upon the data offered by the national government, each prefecture is coming up with the estimate of the necessary number of beds and the estimated population. The data used for the estimates done by the prefecture for the number of necessary beds in 2025 is offered by our institute. So we're proud that our research is contributing to the public policy making in a healthcare system and long-term care system. So please take a look at this graph, which explains what I've verbally explained. On the left is the number of beds necessary in 2025, and on the left, the current number of actual beds today. So the red portion accounts for big cities, and currently the number of beds necessary is over the number of actual beds installed. And as I said, the pace of aging would differ region by region, but if we are to think about effective system, we need to give more authority to the municipalities, and that is why decentralization is progressing rapidly. Finally, I would like to mention another serious challenge, which is dementia. With longer life expectancy, how will the trend be in terms of the number of dementia patients? Professor Ninomiya of Kyushu University has obtained budget from MHLW to conduct an estimate on the future estimate of the number of dementia patients. Kyushu Daigaku is doing a project in Hisayamachi in Fukuoka Prefecture, and they've been involved in medical and epidemiological study for a long period of time. And in public health, Hisayamacho study is a well-known study, and they are using that in order to come up with an estimate of dementia patients in the future. And as a result of Hisayamacho study, they did an analysis of prevalence of dementia and risk factors, and the risk factors are age, women, and another risk factor is diabetes. So diabetes can lead to dementia. And here I'm going to skip talking about diabetes, but this is prevalence of dementia as taken in 2012. So as you can see, if you're over 80, the increase in the number of patients is more significant, and the prevalence amongst women is higher than male. And this is used to come up with a future estimate. And we factored this in to our projection of population in the future. In 2012, there were 4.62 million dementia patients, which is 15% of those who are 65 and above. The prevalence by age bracket, if we assume that the incidence per age bracket remains unchanged from 2012, what would be the actual number of population? 2025, it is estimated that there will be 6.75 million dementia patients, which will account for 19% of those who are 65 and above. The bottom half indicates the estimated number on the assumption that there will be some increase in the population. At any rate, the number of elderlies with dementia will increase, and there's no pandemia, so it's not just long-term care and medical treatment necessary. A diverse response would be necessary. The national government has come up with this new Orange Plan, which is a strategy to respond to dementia covering various aspects. And dementia could be identified as the highest priority issue in any measure with regards to longevity. I've been talking about the current status and challenges in healthcare and long-term care due to longevity and lower birth rates. So let me try to summarize. Total population is declining, but late elderlies will increase until 2030, but young population will decline. So the proportion of late elderlies against total population will be as high as 25% by 2060. The increase of elderlies will occur most in 3 big cities where there are several baby boomers, and the population will decline in rural cities. This leads to increase in social security cost, and that will further exacerbate the burden on the working age population. And the increase of social security expense is higher than GDP increase, and the burden on the working age population is already increasing. The impact of longevity is bigger in long-term care than medical care experience, which indicates that a bigger challenge is the sustainability of the long-term care insurance system. The gap between life expectancy and health life expectancy is longer for women than men, and women have higher requirement of higher degree of care in late elderlies, and the incidence of dementia is higher amongst women. So women must be the focus. And in terms of medical care, there has to be a shift from acute to chronic disease, and from hospital-based to community-based medical service. And the increase of elderlies is different region by region, so community-based reform is necessary. Dementia prevalence amongst late elderlies is high, and there are estimates that say 20% of 65 and above will be dementia in 2025. So we need to have more policies to respond to dementia. Thank you. Dr. Endo, thank you very much.